Assalamualaikum and good day to everyone. Today we are going to learn about the calcium regulating hormone. The learning objective for today's lecture is to understand the role of hormone involved in regulation of plasma calcium. We have a few subtopics including calcium in circulation, calcium homeostasis, and multiple hormones that involve in the regulation of calcium, including parathyroid hormone or PTH, calcitonin, and vitamin D. There are a total of 10 mg per deciliter of calcium concentration in the blood. Majority of it is ultrafiltrable, 60%, that consists of complex 2 anions, 10%, and ionized calcium, 50%. Ionized calcium is the only form of calcium that is biologically active, whereas the 40% of total calcium is bound to plasma protein, and the main plasma protein bind to the calcium is albumin. Hypocalcemia. Hypocalcemia is a state where there is decrease in the plasma calcium concentration. There are multiple signs and symptoms indicate hypocalcemia. Hyperreflexia, spontaneous twitching, muscle cramps, tingling and numbness among the signs and symptoms of hypocalcemia. There are specific indicators of hypocalcemia, including Chauvet sign, or twitching of the facial muscles elicited by tapping on the facial nerve, and Trousseau signs, which is a carpopedal spasm upon inflation of a blood pressure cuff. So how this hypocalcemia can cause twitching and cramping of skeletal muscle? Calcium is required for cross-bridge cycling in muscle contraction. However, the calcium that initiates the cross-bridge cycle in skeletal muscle contraction is intracellular calcium. Decreased extracellular calcium causes increased excitability of excitable cells, including sensory and motor nerves and muscle. Decreased extracellular calcium lowers the threshold potential. By lowering threshold potential, less inward current is required to depolarize the threshold and to fire action potential. Thus, hypocalcemia produces tingling and numbness and spontaneous muscle twitches. For Chauvet sign and Trousseau sign, you can click to the link in the slide. There are several important factors that can influence calcium in the plasma. The first factor is changes in plasma protein concentration. Number 2, changes in complexing anion concentration. And number 3, acid-base disturbance. And these changes will be physiologically significant if they alter the ionized calcium concentration, which is the biologically active form of calcium. The changes in plasma protein concentration. The alteration of total calcium concentration is the same direction as protein concentration. Increase in protein concentration will be associated with increase in total calcium concentration. In contrast, decrease in protein concentration are associated with decrease in total calcium concentration. Because changes in plasma protein concentration usually are chronic and develop slowly over time, They do not cause a parallel change in ionized calcium concentration. The regulatory mechanisms, such as those involving parathyroid hormone, sense any transient change in ionized calcium concentration and have time to make the appropriate correction. Changes in anion concentration can influence the level of calcium in the circulation. The alteration of ionized calcium concentration can occur by changing the fraction of calcium complex with anions. In this case, we are going to use phosphate as an example. If the plasma phosphate concentration increases, the complex of calcium increases, thereby decreasing the ionized calcium concentration. And if the plasma phosphate concentration decreases, the complex of calcium decreases and the ionized calcium will increase. Acid-base abnormalities such as acidemia or alkalemia can change the level of calcium in the blood. Alteration of the ionized calcium concentration can occur by changing the fraction of calcium bound to plasma albumin, as illustrated in the next figure. Albumin has negatively charged sites, which can bind either to H+ ions or calcium's 2+ ions. In acidemia, where the H+ is elevated in the blood, more H+ will bind to the albumin, leaving fewer sites for calcium to bind. Free ionized calcium concentration increases because less calcium is bound to albumin. Whereas in alkalemia, deficit of H+ in the blood, and these less H+ will be bound to albumin, leaving more sites for calcium to bind. In alkalemia, for example, in acute respiratory alkalosis, the free ionized calcium concentration decrease, often accompanied by symptoms of hypocalcemia. Calcium homeostasis involves three main organs. The first one is intestine, the second one is renal, and the third one is bone. The relationship between the organ systems and the hormones in maintaining calcium balance is depicted in this figure, right? To illustrate, the person shown in this figure is said to be in calcium balance. In this person, net excretion of calcium by the kidney is equal to net absorption of calcium from GI tract. If, let's say, the person is ingesting 1000 mg of calcium daily, approximately 350 mg is absorbed from the GI tract, a process that is stimulated by the active form of vitamin D. The active form of vitamin D is 1,25-dihydroxycholecalciferol. However, about 150 mg per day is secreted into the GI tract in salivary, pancreatic, and intestinal fluids. Thus, the net absorption of calcium is 200 mg per day, where the 350 mg absorption is deducted to the 150 mg secretion. And the remaining 800 mg per day of the 1000 mg ingested is excreted in the feces. The absorbed calcium will enter the calcium pools in ECF, right? The person depicted in this figure is presumed to have no net gain or loss of calcium from bone, right? Meaning that the bone deposition and the bone resorption is the same. Nevertheless, there is a continuous bone remodeling in which new bone is formed and old bone is resorbed. Bone resorption is stimulated by PTH and 1,25-dihydroxycholecalciferol and is inhibited by the calcitonin. Ultimately, to maintain calcium balance, the kidney must excrete the same amount of calcium that is absorbed from the GI tract, in this case 200 mg per day. And the renal mechanism, including the filtration of calcium followed by extensive reabsorption, is being discussed in another module. Parathyroid hormone. The role of parathyroid hormone or PTH is to regulate the concentration of calcium in ECF, for example, in plasma or serum. When the plasma calcium concentration decreases, PTH is secreted by parathyroid glands. PTH has physiologic action on bone, kidney, and intestine that are coordinated to increase the plasma calcium concentration back to normal. As shown in the figure, when the total plasma calcium is in the normal range, for example, 10 mg per deciliter or higher, PTH is secreted at low level. However, when the plasma calcium concentration decreases to less than 10 mg per deciliter, PTH secretion is stimulated, reaching maximal rates when the calcium concentration is 7.5 mg per deciliter. The relationship between total calcium concentration and PTH secretion is shown in the figure, although it is actually the ionized calcium concentration that regulates secretion by the parathyroid gland. Parathyroid hormone secretion is regulated by plasma calcium concentration. The response of parathyroid glands to decrease in ionized calcium concentration is remarkably prompt, occurring within seconds. It's very fast. The faster the ionized calcium falls, the greater the PTH secretory response. The mechanism of PTH secretion. The parathyroid cell membrane contains calcium sensing receptors that are linked via G protein to phospholipase C. When the extracellular calcium concentration is increased, calcium binds to the receptor and activates phospholipase C. Activation of phospholipase C leads to increased levels of IP3 calcium, which inhibits PTH secretion. When extracellular calcium is decreased, there is decreased calcium binding to the receptor, which stimulates PTH secretion. In addition to rapid changes in PTH secretion, the long-term changes or chronic changes in plasma calcium concentration will alter the transcription of gene for pre-pro-PTH, synthesis and storage of PTH, and growth of the parathyroid glands. In chronic hypocalcemia, where it decreased plasma calcium concentration, causes secondary hyperparathyroidism, which is characterized by increased synthesis and storage of PTH, and hyperplasia of parathyroid glands. In chronic hypercalcemia, increased plasma calcium concentration causes decreased synthesis and storage of PTH, increased breakdown of stored PTH, and release of inactive PTH fragments into the circulation. For magnesium, same but less important effects on PTH secretion. Like hypocalcemia, hypomagnesemia stimulates PTH secretion, and hypermagnesemia inhibits PTH secretion. An exception is the case of severe hypomagnesemia, associated with chronic magnesium depletion. For example, in alcoholism, severe hypomagnesemia inhibits PTH synthesis, storage, and secretion by the parathyroid gland. This figure is showing you the action of PTH secretion on bone, kidney, and intestine. Reduced plasma concentration of calcium will increase the PTH secretion. This will have direct effect to bone, kidney, whereas it has indirect action to intestine. All right. In bone, it will increase bone resorption, and in kidney, it will reduce phosphate reabsorption, producing phosphaturia, increase calcium reabsorption, and increase urinary cyclic AMP. All of this will increase the plasma calcium toward normal, whereas in intestine, the increased calcium absorption is through the indirect via 125 dihydroxycholecalciferol. The action of parathyroid hormone in bone. Right? In bone, the PTH receptors are located on osteoblast, but not on osteoclast. The direct action in osteoblast initially and transiently, PTH will cause an increase in bone formation by a direct action of osteoblasts. This brief action is the basis of the usefulness of intermittent synthetic PTH administration of the treatment of osteoporosis. However, in osteoclast, it has indirect action. In a second long-lasting action on osteoclast, PTH causes an increase in bone resorption. This second action on osteoclast is indirect. How indirect? It is mediated by cytokines released from osteoblasts, and these cytokines then increase the number and activity of the bone-resorbing osteoclasts. Thus, the bone-forming cells, osteoblasts, are required for the bone resorbing action of PTH on osteoclasts. When PTH levels are chronically elevated, as in hyperparathyroidism, the rate of bone resorption is persistently elevated, which increases the serum calcium concentration. The overall effect of PTH on bone is to promote bone resorption, delivering both calcium and phosphate to ECF. Hydroxyproline that is released from bone matrix is excreted in urine. Alone, the effects of PTH on bone cannot account for its overall action to increase the plasma ionized calcium concentration. The phosphate released from bone will complex with calcium in ECF and limit the rise in ionized calcium concentration. Thus, in additional mechanism, must coordinate with the PTH effect on bone to cause the plasma ionized calcium concentration to increase. What is phosphaturic? Phosphaturic is excretion of phosphates in the urine. And what is hydroxyproline? Hydroxyproline is a hydroxylated amino acid which is most concentrated in collagen in urine, indicates turnover of bone matrix, often caused by osteoporosis. There are two actions of parathyroid hormone in the kidney. Number 1, PTH will inhibit phosphate reabsorption by inhibiting sodium phosphate co-transport in the proximal convoluted tubule. As a result of this action, PTH causes phosphaturia and increased excretion of phosphatine in urine. The cyclic AMP generated in cells of the proximal tubule is excreted in urine and is called nephrogenous or urinary cAMP. The phosphaturic action of PTH is critical because the phosphate that was reabsorbed from bone is excreted in the urine. This phosphate would have otherwise complex calcium in ECF. Excreting phosphate in urine allows the plasma ionized calcium concentration to increase. The second action of PTH on kidney is by stimulating the calcium reabsorption. The second renal action of PTH is on the distal convoluted tubule and complements the increase in plasma calcium concentration that resulted from the combination of bone resorption and phosphaturia. Action of parathyroid hormone in small intestine. PTH does not have direct actions on the small intestine as we discussed in the previous slide. Although indirectly it stimulates intestinal calcium absorption via activation of vitamin D. PTH stimulates renal 1-alpha hydroxylase, the enzyme that converts 25-hydroxycholecalciferol to the active form 1,25-dihydroxycholecalciferol. In turn, 1,25-dihydroxycholecalciferol stimulates intestinal calcium absorption. These are the pathophysiology of PTH, including primary hyperparathyroidism, surgical hypoparathyroidism, pseudo-hypoparathyroidism, humoral hypercalcemia of malignancy, increased PTH-RP, and chronic renal failure. So you can see the level of PTH, the level of 1,25-dihydroxycholecalciferol in bone, urine, serum calcium, and serum phosphate. Calcitonin is secreted by the thyroid gland, in particular parafollicular cells or C cell. The calcitonin gene directs the synthesis of procalcitonin, and a signal peptide is cleaved to yield procalcitonin. Other peptide sequences are then removed, and the final hormone calcitonin is stored in secretory granules for subsequent release. The major stimulus for calcitonin secretion is increased plasma calcium concentration. Contrast this with the stimulus of PTH secretion, decreased plasma calcium concentration. The major action of calcitonin is to inhibit osteoclastic bone resorption, which decreases the plasma calcium concentration. In contrast to PTH, calcitonin does not participate in the minute-to-minute regulation of plasma calcium concentration in human. In fact, a physiologic role for calcitonin in human is uncertain because neither thyroidectomy with decreased calcitonin levels nor thyroid tumors with increased calcitonin levels cause a derangement of calcium metabolism, as would be expected if calcitonin had important regulatory function. Vitamin D, with the help of PTH, is the second major regulatory hormone for calcium and phosphate metabolism. The roles of PTH and vitamin D can be distinguished as follows. The role of PTH is to maintain the plasma calcium concentration, and its action are coordinated to increase the ionized calcium concentration toward normal. And the role of vitamin D is to promote mineralization of new bone, and its action are coordinated to increase both calcium and phosphate concentration in plasma, so that these elements can be deposited in new bone mineral. Two sources of cholecalciferol in the body. It is ingested either by the diet or synthesized in the skin from 7-dehydroxycholesterol in the presence of UV light. It is hydroxylated in the liver to form 25-hydroxycholecalciferol, which also is inactive. This hydroxylation step occurs in endoplasmic reticulum and requires NADPH, oxygen, and magnesium, but not cytochrome P450. The 25-hydroxycholecalciferol is bound to an alpha globulin in plasma and is the principal circulating form of vitamin D. In the kidney, the 25-hydroxycholecalciferol undergoes one of two routes of hydroxylation. It can be hydroxylated at the C1 position to produce 1,25-dihydroxycholecalciferol, which is the physiologically active form, or it can be hydroxylated at C24 to produce 24,25-dihydroxycholecalciferol, which is inactive. Regulation of vitamin D synthesis. whether the renal cells produce 1,25-dihydroxycholecalciferol, the active metabolite, or 24,25-dihydroxycholecalciferol, the inactive metabolite, depends on the status of calcium in the body. When calcium is reduced with an adequate dietary intake of calcium and normal or increased plasma calcium concentration, the inactive metabolite is preferentially synthesized because there is no need for more calcium. When calcium is insufficient with a low dietary intake of calcium and decreased plasma calcium concentration, the active metabolite is preferentially synthesized to ensure that additional calcium will be absorbed from the GI tract. The production of active metabolites, 1,25-dihydroxycholecalciferol, is regulated by changing the activity of the 1-alpha hydroxylase enzyme. 1-alpha hydroxylase activity is increased by each of the following three factors. The first one, decreased plasma calcium concentration. The second one, increased circulating levels of PTH. And the third one is decreased plasma phosphate concentration. Actions of vitamin D. The overall role of vitamin D, 125-dihydroxycholecalciferol, is to increase the plasma concentration of both calcium and phosphate, and to increase the calcium phosphate product to promote mineralization of new bone. To increase plasma calcium and phosphate concentration, vitamin D has coordinated action on intestine, kidney, and bone. Because 125-dihydroxycholecalciferol is a steroid hormone, its mechanism of action involves stimulation of gene transcription and synthesis of new protein. Pathophysiology of vitamin D. In children, vitamin D deficiency causes rickets, a condition in which insufficient amounts of calcium and phosphate are available to mineralize the growing. In adults, vitamin D deficiency results in osteomalacia, in which new bone fails to mineralize, resulting in bending and softening of weight-bearing bones. Vitamin D resistance occurs when the kidney is unable to produce the active metabolite 1,25-dihydroxycholecalciferol. This condition is called resistant because no matter how much vitamin D is supplemented in the diet, it will be inactive because the C1 hydroxylation step in the kidney is absent or is inhibited. Vitamin D resistance can be caused by congenital absence of 1-alpha hydroxylase or more commonly by chronic renal failure.